Estadística aquí en la ciudad de Pasto, en la Universidad De Nariño. Tendremos nuestra conferencia inaugural a las 3:30 de la tarde. Por ahora los invito a presenciar el curso Consideraciones Estadísticas en el Diseño de Ensayos Clínicos para la Implementación en la Ciencia. El curso está impartido por la profesora Chari Messenger. La profesora Chari Messenger es profesora y directora de la División de Bioestadística en el Miami Miller School of Medicine, donde es profesora desde el 2002. Después de obtener su doctorado en bioestadística en la Universidad de Michigan, ella ha trabajado como directora de bioestadística del GCRC, ha sido directora del Biostatistics Core of the Diabetes Research Institute, del Instituto de Investigación en Diabetes, y actualmente sirve como directora del Instituto de Ciencias para el diseño en la investigación y los componentes bioestadísticos de el Miami Clinical and Transnational Science Institute. La doctora Messenger ha focalizado su investigación principalmente en el área de la diabetes, tiene una experiencia muy extensa en la aplicación de métodos estadísticos y en el diseño de ensayos clínicos y en el análisis de estudios observacionales. Thank you, Professor Messenger, for accepting our invitation, and the floor is yours.
Buenos días. Okay. Voy a tratar de comunicar un poco de español. Buenos días, me siento muy honrada y agradecida por la invitación a Pasto para participar en este simposio tan especial. Me llamo Sherry Messenger y soy mamá de 3 maravillosos jóvenes adultos. Comparto mi hogar con 3 perros y un gato y estoy casada con un hombre maravilloso que me ha acompañado en este viaje a Pasto y me apasiona viajar y hacer ejercicio. Aunque hablo algo de español, lo he ido aprendiendo a lo largo de mi vida. Me siento más cómoda conversando de manera informal que dando una charla formal en este idioma. Por eso, tanto la conferencia como el curso los impartiré en inglés. Ahora me gustaría contarles un poco sobre mi trayectoria profesional. Crecí en Florida, muy cerca de Miami, y realicé mis estudios de pregrado y maestría en ingeniería y en la Universidad de Florida. Más adelante continué mi formación con una segunda maestría y un doctorado en bioestadística en la Universidad de Michigan. En 2002 me incorporé a la Facultad de Medicina Miller de la Universidad de Miami en el Departamento de Ciencias en la Salud Pública. Ahí he trabajado desde entonces y actualmente soy profesora y directora de la División de Bioestadística y Bioinformática. Además, tengo el gusto de liderar un grupo colaborativo de bioestadísticos que apoya la investigación clínica y translacional en toda la institución. Además, enseño en los programas de posgrado en bioestadística y colaboro en la investigación clínica y translacional. ¿Me entendieron? Okay. From this point, I'm going to speak in English. Is that okay? If you don't understand me, if there's anything I'm saying too fast, please feel free to stop me and ask me to repeat. I have a lot of respect that you are able to understand this material in English. I have so much respect for that. Okay, so the session today is going to focus on the design and statistical considerations that are unique to clinical trials conducted within the context of implementation sciences. Who here knows what implementation sciences are? Not yet. You will. So implementation science trials are often conducted in complex real-world settings where interventions are adapted, delivered by diverse providers, and embedded within systems. As a result, the design choices and statistical approaches we need to reflect that complexity. We'll begin by reviewing core design types used in implementation trials, including cluster randomized designs, stepped wedge designs, and SMART designs. I'm going to define what all of these are. You should not know what they are yet. From there, we will discuss how statistical considerations differ in implementation trials compared to traditional efficacy trials. For example, we often face multi-level data structures, such as patients nested within providers, right? So the patients are within the same provider, or clinics within health systems, which require special analytic strategies. We will also explore how things like intra-cluster correlation, design effect, and unit of randomization directly impact power and sample size. We will introduce modeling approaches like mixed effects models and generalized estimating equations that account for clustering and time-varying exposures. I'm sure many of you are familiar with some of this methodology. It's the application that will be unique. The key message here is that the design and analysis and implementation trials must be both rigorous and pragmatic. The goal is to produce actionable, generalizable insights while maintaining validity and feasibility in real-world contexts. This foundation will help us evaluate and design trials that not only ask what works, but asks how do they work, for whom do they work, and under what conditions do they work. Is this speed okay that I'm speaking? Okay. So today is all about laying the foundation. You've got me for 3 days, so we're going to start with laying a foundation, defining terms, understanding frameworks, and exploring the design and analytic considerations that are specific to implementation-focused trials. We're going to begin with some context. What is implementation science? How is it different from traditional clinical research? And why is it needed? Then we're going to walk through some foundational elements like understanding implementation strategies, outcomes, and theory-driven approaches before we dive into kinds of study designs that we use in this field. From there, we're going to discuss the T0 to T4 translational research continuum. We will explore how implementation outcomes differ from clinical outcomes, and we will look at the statistical complexities we face when conducting trials in a real-world, multi-level context. We'll spend some time talking about hybrid trials and pragmatic trials, including the PRECIS-2 tool, which helps researchers think carefully about how real-world trials operate. We will also look at clustering, intra-cluster correlation, and what this means for trial design, sample size, and analysis. Finally, we'll close the day today with an overview of modeling strategies, setting the stage for deeper discussions in the next few days. So let this outline serve as your roadmap for today's journey. Feel free to ask me questions along the way. This is a space for shared learning. Okay, so let's begin by asking a foundational question. What is traditional clinical research? How many people here work in clinical research or want to work in clinical research one day? Okay, well then now I've got that. This framework has historically guided how we evaluate new medical interventions from drugs to behavioral therapies. So let's look at this. Oh, see, now I keep forgetting to do this. This is what I'm supposed to do. If I forget, please remind me. Somebody tell me to change the slide. Okay, so the first box is about seeking to determine whether the interventions are efficacious or effective. So traditional clinical research is primarily concerned with efficacy and effectiveness. So does anyone here know the difference between efficacy and effectiveness? They're different words. Efficacy asks the question, does the intervention work under ideal conditions? Think of it as like a proof of concept test. Can this treatment show a benefit in a tightly controlled, maybe experimental setting, such as a clinical trial, with highly selected participants? Effectiveness takes it one step further, and if you ask me, it's truly what matters. It considers, does the treatment work under real-world conditions? This often comes later in the research pipeline. So the second box says typically conducted in controlled or ideal conditions. These studies are usually conducted under highly controlled settings, clinical trials, right? There's usually very strict eligibility criteria for people to participate in a trial. There are very standardized protocols. There's intensive monitoring and follow-up. And this controlled environment reduces confounding and variability. That's one of the reasons why we have to control so much, which improves internal validity, which is the ability to say confidently that any effect is due to the intervention itself. However, it often comes at the cost of what we call external validity, meaning the results may not really generalize well to real-world settings or diverse populations. So the third box has a focus on clinical outcomes, safety, efficacy, or effectiveness. So traditional trials generally focus on a limited set of clinical endpoints. So what do I mean by this? Clinical outcomes such as disease progression, survival, symptom resolution, something that can be measured or observed in a clinical setting. Sometimes they look at safety outcomes, like capturing side effects or adverse events. Efficacy and effectiveness outcomes, like asking, does the intervention work, either ideally or practically? These outcomes are important, they're crucial, but they don't always reflect implementation outcomes, like, we're gonna introduce all of these, feasibility, acceptability, sustainability, which are central in implementation sciences. The fourth box is about designs which include randomized controlled trials or cohort studies. The letter. We all saw this in COVID, right? There were many, many clinics and hospitals that were understaffed. So even though there might have been treatments for patients, there wasn't a way to be able to deliver them properly. Does that make sense? Okay, so this is where implementation science and its complementary research design come in. Okay, so what is implementation science? Now that we've discussed what traditional clinical research is, let's talk about what is implementation science, which is a newer but increasingly vital field. While traditional research asks whether an intervention works under ideal conditions, implementation science asks, how do we make it work in the real world, and how do we sustain it over time? Okay, so the first is about an EBI, or evidence-based intervention, might be a therapy, it might be a screening tool, it might be a public health program or a care coordination strategy. But EBIs often sit on a shelf, underused or inconsistently applied, especially when we have a lack of resources or complexity to our healthcare environments. Implementation science studies the process of how to integrate these EBIs into routine care across diverse real-world contexts. The focus is on adoption, fidelity, sustainability, and real-world application. We will talk about all of these in more detail, but implementation research focuses on very different outcomes than the traditional trials. So we're not really measuring the clinical outcomes. We're measuring outcomes including things like adoption. Are people in systems actually using the intervention? Fidelity. Is it being used as it is intended to be used? Sustainability. Does it persist over time, or does it fade once the study ends? Reach and penetration. Is it reaching the populations who need it? This is important, because if there's a need in pockets of the population and the treatment can't reach them, then it's failing to do what it was supposed to do. These metrics go beyond effectiveness. They reflect how well the interventions are embedded into practice and how they perform across different. Such as a lack of staff training, or poor fit with clinic workflows, or limited reimbursement. And what facilitators help, like leadership support, champions, existing infrastructure. Understanding these factors helps us tailor implementation strategies and increases the likelihood of success in the real world. The fourth box involves multiple stakeholders, clinicians, administrators, and patients, and policymakers. Finally, implementation science is inherently multi-stakeholder. It isn't about publishing findings. It's about working collaboratively with clinicians who deliver care, administrators who run systems, and patients who receive care, and policymakers who shape incentives. These voices are essential in identifying implementation barriers, co-designing solutions, and ensuring that interventions meet local needs. It's a team science approach with strong emphasis on contextual relevance and community engagement. So while traditional research tells us whether an intervention might work, implementation science tells us how to get it to work and to keep it working across the wide range of complex real-world systems where care is actually delivered. So in these 3 days, we're going to look at some of these frameworks, designs, and methods unique to implementation science and how they complement traditional traits. We will get to the statistics and the math, but I have to give you the foundation first. So be patient. Okay, so what is an EBI? Let's talk a little bit more about what is an evidence-based intervention. You didn't remind me, see? Okay. So let's take a moment to define the core building block of implementation science, the EBI, evidence-based intervention. At the core, the EBI is an intervention that is backed by high-quality, rigorous scientific evidence, not opinion, not intuition, but So this slide gives us a side-by-side comparison of traditional clinical research and implementation science. The two are complementary but distinct approaches within the research ecosystem. We can break it down into 4 dimensions: the key question, the study environment, the primary outcomes, and the stakeholders. We can clearly see how the focus shifts when we move from testing an intervention to putting it into practice. So again, in traditional research, the question is, does it work? This is under highly controlled and idealized study conditions. In implementation science, the question is, how do we make it work? This means identifying and addressing the real-world barriers to applying the intervention broadly and effectively. It's not enough that it works. We must ensure that it can work across diverse settings and populations. So we're shifting from efficacy to implementation feasibility. That's what's at the heart of implementation science. The study environment often takes place in a controlled setting with a traditional research design, such as an academic hospital or a research unit, where protocols are followed precisely and our participants are carefully selected using eligibility criteria, like in a clinical trial. Implementation science takes place in the real world, the busy, messy clinic, the community health center with the screaming children and the upset parents, or school-based programs where the chaos of everyday operations introduces variability, right? So that's intentional. We want to know how the intervention performs under the kinds of conditions where all of this heterogeneity and variability and other issues exist, but this is where the interventions will actually be used. The contrast highlights the difference in what we call internal validity versus external validity. Traditional research maximizes the internal, while implementation science is all about emphasizing generalizability. The primary outcomes of traditional trials are those from clinical metrics. Is the treatment effective at reducing symptoms or mortality? Is it safe? Does it meet predefined efficacy thresholds? In implementation studies, our outcomes are implementation metrics, sort of like adoption, are people using it? Fidelity, are they using it as intended? Sustainability, will it be used after the trial ends? Acceptability, do users and providers actually want it? They don't want it, they're not going to use it, right? And the cost, that's a big one. Is it affordable? Is it scalable? I mean, cost is prohibitive to treatment all the time, right? And then on top of that, what happens is that we have some people can afford it, some people can't, so we're introducing disparity. But this difference in outcome is what drives the differences in study design, analysis, and interpretation. That's why I'm spending this time on this now, because we're going to get into this when we go into methods of analysis that take into account these nuances in the differences of outcomes. The stakeholders are different too. Traditional research focuses on a narrow group, primarily researchers, regulators, and patients participating in trials, where implementation science involves a much broader network, including clinicians and frontline staff, healthcare administrators, community leaders, policymakers, and of course the patients and their families. This broader scope reflects the reality that getting something into practice is not just a scientific challenge, it's an organizational and social one too. Implementation success depends on aligning incentives, addressing context, and engaging the people who will ultimately deliver and experience the intervention. So the other thing I want to say is that between traditional research and implementation science, one asking again, does this work in ideal conditions? And the other one is, how do we get it to work in the real world? These two are not in competition. It's not one or the other. They are part of a continuum of science. Implementation science builds on the evidence generated by traditional research and ensures that it reaches the people and settings where it's most useful and needed. So let's take a step back for a minute and talk about why it matters, not just academically, but in terms of real-world impact on health outcomes, equity, and system transformation. So this slide covers 3 fundamental reasons why implementation science matters. The first, it bridges the gap between research and real-world use. One of the core challenges in healthcare is often what is called the research to practice gap. We have thousands of effective evidence-based interventions developed through traditional research means, but many of these interventions never actually make it to everyday practice, or if they do so only partially, inconsistently, maybe to only certain groups who have access, or after many, many years. A common statistic cited that it can take 17 years for just 14% of clinical research findings to be adopted into routine care. Think about that for a minute. 17 years, that's a long time. Implementation science is designed to shorten that gap by studying how to get effective interventions into practice faster and more consistently across populations. It ensures intervention benefits diverse populations. Another critical reason implementation science matters is that it explicitly emphasizes real-world populations and equity. Traditional research often excludes or underrepresents groups that are harder to deal with, really, like older adults, rural populations, in the US, non-English speakers, or those with multiple chronic conditions. So even if an intervention is shown to be effective in trials, we can't assume it will work or be acceptable in those diverse groups. Implementation science actively evaluates how interventions perform in different settings, populations, and contexts, helps tailor interventions so that they are accessible and appropriate across a range of cultural, social, and structural environments, and this helps ensure that no group is left behind when we scale up evidence-based care. It promotes equity, efficiency, and sustainability in healthcare. Finally, implementation science supports broader health system goals. By equity, we mean by ensuring underserved populations. By efficiency, we mean by reducing wasted resources on interventions that aren't adopted or used correctly. And by sustainability, we mean by identifying implementation strategies that are not just effective, but are able to be maintained over time. It's not just about getting something into practice once. It's about eliciting change in a way that sticks and adds value to systems in the long term. Okay, so this just summarizes what I've just said. Traditional research asks, does it work? Implementation science asks, how do we get it to work? Everywhere and for everyone. Both are essential for improving population health. So thank you. No, that's just the summary slide, so I'm going to go really fast through it. You've already heard me say most of this. I just want to make sure that the distinctions are clear. Okay, so let's walk through this example, which focuses on hypertension control in the United States. Only 55% of adults with hypertension have their condition under control in the US. This is a startling statistic. Despite decades of research and clinical guidelines, nearly half of adults with hypertension, which is high blood pressure, do not have their blood pressure under control. This is a big problem, especially since hypertension is often an underlying cause of stroke, right? And nobody wants that. It's a major driver of cardiovascular disease, stroke, kidney failure, and healthcare costs. But yet, the tools to control blood pressure, like medications, monitoring, lifestyle changes, counseling, these are very well established and known. This statistic illustrates the no-do gap. We know what works, but we're not consistently doing it at scale. Effective treatments exist, but uptake is inconsistent, and this is the heart of the problem. We have strong evidence-based interventions, such as team-based care models that include nurses and pharmacies. We have clinical decision support tools, standardized medication protocols, and outreach systems to follow up for adherence and follow-up. But these have been shown in trials to significantly improve blood pressure control, but across many areas of clinics, health systems, and communities, uptake and fidelity of these interventions is very inconsistent, and that inconsistency leads to the inequities and avoidable harm. This is not a failure of science. Science did its job by finding the treatments. It's a failure of implementation. Okay, so this example helps us make the case that knowing what works isn't enough. We need to understand and address the real-world factors that determine whether an intervention will be used, sustained, and scaled. Identifying and testing strategies to ensure evidence-based interventions are actually delivered equitably and effectively. Okay, so this just builds up a little bit more on the example that I've been talking about of real-world applications of implementation science using hypertension control as an example, bringing together the key components of implementation science processes, identifying a problem first, selecting an evidence-based intervention, understanding real-world challenges, and applying an implementation strategy, then measuring meaningful outcomes. So let's walk through it step by step. The problem in this example is one of the leading risk factors for cardiovascular disease, hypertension, and it's the #1 cause of death globally. Despite its preventability and availability of effective treatments, hypertension is poorly controlled in nearly half of United States adults, and I would argue probably in many other countries worldwide. This makes it an ideal case for exploring where implementation science is needed. We already know that there are treatments that work. There are standardized treatment protocols, for example, medications, team-based care, and other things that are supported by randomized clinical trials and have been incorporated into the national quality initiatives. But as we've discussed, having the intervention isn't the issue. The issue is in the real-world application. In the real world, the adoption of these treatments varies very widely. Some clinics integrate team-based care and protocol-driven treatment, others don't, often due to resource constraints, competing priorities, or just lack of support. The challenge is particularly acute in under-resourced settings like rural clinics, safety net systems, or community health centers, where staff are overstretched and infrastructures are very weak. So implementation science would step in with strategies tailored to these barriers, such as training and engaging clinical leadership, helping teams understand the benefits of standardized protocols, and addressing the resistance to change through champions or opinion leaders. Embedding protocols into electronic health records makes it much easier to follow the protocol through alerts, templates, or clinical decision support tools. Think your iPhone app with an app giving you an alert to remember to take your medication. Monitoring performance and offering feedback, providing clinicians with data on their control rates, recognizing high performers, coaching lower performers. So by applying these strategies, we have seen improved blood pressure control rates and in some cases, narrowing of health disparities. So now let's see how this hypertension example would play out differently in a traditional clinical trial versus an implementation study. I didn't do it again. That's where we are now. Keep forgetting to change the slide. Okay, so this slide shows a side-by-side comparison of the same clinical issue. Hypertension approached through two different research lenses. Actually, no, this slide does not show that, what has happened here. Give me 1 second. Okay, it's fine. So in the traditional clinical trial, the focus is typically on testing the new drug or the intervention. Does this new medication reduce blood pressure more than a placebo? The setting would be highly controlled, selected patient populations, and standardized conditions. This is critical for determining efficacy, ensuring safety, and gaining regulatory approval. But remember, efficacy does not equal uptake or real-world success. In the implementation trial, we asked the question, how do we ensure that the rural clinics actually adopt these protocols? This trial would examine things like the training programs for clinicians, outreach strategies to engage patients. Again, it's about how to get it used. Both trials serve essential roles. One builds the evidence, one translates it into practice. So these are the targets for implementation science. This is a critical concept to understand. Implementation does not happen in isolation. It occurs across multiple interacting levels of healthcare or community systems. For an evidence-based intervention to be successfully adopted and sustained, implementation efforts must often target more than one level at the same time. So let's walk through these targets. Implementation science targets change at multiple levels. This sets the foundation. It is not just about the patients or just about the providers. It's about addressing the broader ecosystem where healthcare is delivered, and recognizing that change requires alignment across all of the levels. On the patient level, it focuses on what patients know, believe, and do. Implementation efforts may include education on how an intervention works, addressing attitudes or stigma, supporting self-management. At the provider level, frontline clinicians need training on how to deliver the intervention, or maybe decision support tools, such as clinician reminders or order sets, and integration of tasks into existing workflows. So for example, for the patient level, a diabetes intervention might include text message reminders or culturally tailored health coaching to support lifestyle changes. Where at the provider level, a provider might need an alert in the EHR, prompting them to use a standardized hypertension protocol and workflow support to make it feasible. Without leadership buy-in, even the most motivated providers can't succeed. The organizational support includes protected time, workflow design, and infrastructure to track and monitor outcomes. And at the community level, interventions often fail if they don't consider the social and community context. At the policy and system level, higher level structures such as reimbursement policies, quality metrics, and regulatory guidelines can either facilitate or block implementation. Implementation strategies must be layered and coordinated. You might need a patient-facing education component, provider-facing decision support, organizational leadership engagement, and alignment with broader health system initiatives, all working together. How am I on time? I think we started late. I don't know where we are on time, so I'm just going to continue. And if I need to stop, somebody will tell me, right? Okay, so implementation strategies. Now that we've talked about what implementation science aims to do and where it targets change, let's turn to the how. That's how we actually make it happen in the real world. This slide introduces something called the ERIC compilation, expert recommendations for implementing change. See, I still did it again. I'm going to keep doing this. Let's start with a landmark effort in the field. It's called the ERIC compilation. ERIC stands for Expert Recommendations for Implementing Change. It's a taxonomy or a structured list of over 70 discrete implementation strategies developed through a Delphi process involving implementation scientists and practitioners. The goal was to standardize the terminology used across the field to help researchers and health systems select, report, and evaluate strategies with greater precision and consistency. Some examples of ERIC strategies: conducting educational meetings, audit and feedback, changing incentive structures, and tailoring interventions to context. These are not one-size-fits-all solutions. They are tools we choose and combine based on the specific barriers and facilitators given in context. So this slide introduces a critical principle in implementation science, the importance of theory-driven implementation. Rather than applying strategies based on intuition, trial and error, we aim to use formal frameworks, models, and theories to guide what we do, why we do it, and how we interpret the outcomes. Theory-driven implementation means that we're using existing conceptual tools, such as behavioral theories, organizational change models, implementation science frameworks, which I will get to in a minute. And these helped us select implementation strategies based on known barriers, adapt those strategies to local context, and evaluate the process and the outcomes of implementation. In short, the theory provides a blueprint, a structured way to think about change and make decisions systematically. Why do we care? Why does it matter? It helps identify mechanisms of change. It aids in choosing context-appropriate strategies, and it supports interpretation of results and increases replicability and scalability. When we use theory to document how and why an intervention was implemented, others can understand the core principles and adapt it to their own context. So in takeaway, theory-driven implementation isn't just academic, it's practical. These are some examples of implementation frameworks that are often used in the field. The first is called CFR, Consolidated Framework for Implementation Research. It's the most commonly used framework in implementation science. It organizes the implementation influences into 5 major domains: intervention characteristics, outer setting, inner setting, characteristics of individuals, and process. It's very helpful for diagnosing barriers and facilitators. TDF is another framework, theoretical domains, and this was developed to help bridge the gap between behavioral theories and implementation practice. This is very useful when designing behavior change interventions or choosing strategies that aim to change clinician or staff behaviors. RE-AIM is a practical evaluation framework often used in public health and community-based interventions. All 3 frameworks help us guide theory-driven implementation. They're not mutually exclusive. In fact, many researchers use CFR to assess context, TDF to inform strategy decision, and RE-AIM to structure evaluations. So this is a table comparing the frameworks. You all will have access to my notes, so I'm not going to go through the table line by line, but it does give you a little bit more clarity as to how the different frameworks are used. And now we get to the introduction to study designs. So this is the statistical stuff that probably is where you all feel more comfortable. So this is a high-level overview of the major categories of study designs used in implementation science and applied health research. And in the next few days, we're going to spend a lot of time talking about these designs and how the theory and the inference of these designs can be used in implementation sciences. We have experimental designs and quasi-experimental designs, and understanding the differences and appropriate uses of these designs is critical for evaluating effectiveness and implementation of interventions in real-world settings. So experimental designs include things like cluster randomized trials. These are groups or clusters, such as schools, clinics, and communities that are randomized to conditions. This is very common in implementation science when individual level randomization isn't feasible, right? It helps minimize contamination and supports delivery of interventions at the system level. Stepped wedge designs is another design where every cluster eventually receives the intervention, but the timing is randomized. And this allows for within and between group comparisons over time. And SMART designs are sequential multiple assignment randomized trials, which are adaptive designs that allows for multiple stages of randomization based on participant response. Overall, experimental designs are ideal when causality and high control are the priority, but they can be resource intensive and sometimes less flexible for real-world settings. Then there are quasi-experimental designs, and there's a whole gamut of them, such as interrupted time series, matched comparison group designs, And these balance rigor and feasibility, especially for evaluating interventions in dynamic or complex real-world settings. So in summary, experimental designs offer strong causal inference, but may require more control and resources. I apologize, I keep forgetting to switch the slide because we're operating on two different ways of doing this, so you have to yell at me when I do that. But these designs help us test both whether strategies work and how they work in the real world settings. We'll be covering these in the next few days. How am I doing on time? I have no idea when this is supposed to end or how much time I have. Can I keep going? Okay, so this slide introduces what's known as the T0 to T4 continuum, which describes the stages of translational research. It's the process of going from bench to bedside to population. And implementation science comes in right there between translation to practice and translation to community. So T0 is preclinical research, T1 is translation to humans, T2 is translation to practice, and this is the traditional domain of a randomized clinical trial or an effectiveness study. And then T4 is that translation to community, which represents the true population health impact. This right here, you can't see my mouse, this is where implementation science comes in. It focuses on how to get the evidence-based interventions into routine practice, which is where we think about adoption, fidelity, integration, and behavior change. This is the how we make it work. So this is a summary slide giving you the differences between clinical and implementation outcomes. We've talked about a lot of this already. It's a summary that has everything in one place. But if you look at the differences in the examples of the outcomes, you'll see that clinical outcomes may include things such as blood pressure reduction, symptom relief, or disease remission, where implementation outcomes would include things like what proportion of providers or sites actually use the intervention? That's adoption. Was the intervention delivered as intended? That's fidelity. Did it get to the intended population? That's reach. Is it maintained over time? That's sustainability. And do stakeholders, meaning patients or providers, find it acceptable? In terms of measurement level, clinical outcomes are usually measured at the individual level. What's my hemoglobin A1C, right? And this focuses on patient level response. Implementation outcomes are often at the system, provider, or organizational level. We might survey a clinic, monitor health records, or evaluate administrative data. Ultimately, the goal of clinical research is to improve individual patient health, but the goal of implementation science is to ensure that effective interventions are delivered broadly, equitably, and sustainably so they can impact population health. Okay, so this slide, I know it's probably very hard for you to see because it's very, very little on the slide, so I'm not going to keep it up here very long. I'm just going to tell you that this is a formally defined document that is referenced in the bottom here that specifically defines the outcomes of acceptability, adoption, appropriateness, and feasibility, and how they are used in real-world implementation studies. Again, you will have my notes, and this reference will give you these formal definitions for these outcomes. It came up really tiny on there. Okay. And so this slide helps frame how implementation outcomes should align with the phase of a project. The implementation research as a process with stages, and just like clinical trials, the outcomes should evolve as the work progresses. In early phase, we're exploring, we're figuring out whether the intervention makes sense in a particular context. In middle phase, we're talking about active implementation. This is where we launch the intervention and want to know how it's actually being used and are measuring things like adoption, fidelity, cost, and penetration, which is how deeply has the intervention reached across the system or target populations. The late phase is the sustainment. This is, okay, is the intervention being used long-term? And is it being integrated in communities? Choosing the right outcomes by phase is essential in study design, your measurement strategy, telling a compelling story, and matching the findings to a funder or policymaker expectations. So it looks like the very top of my slide got cut off there. Okay, so implementation science trials introduce a unique layer of statistical complexity. Unlike traditional clinical trials focused on individual level outcomes, implementation trials deal with multi-level data, varied outcome types, and a dynamic setting, all of which introduce statistical and analytic challenges. So why are implementation studies complex? Number one, they have nested data structures. The outcomes are not independent. Patients are nested within providers. Providers are nested within clinics or hospital systems, and this violates some of our basic assumptions of traditional models. If you ignore clustering, all of your estimates of variability and your standard errors will be smaller than they should be, and your p-values will be way too optimistic. Non-random assignment, especially in the quasi-experimental designs, or where interventions are not randomly assigned, so we might not have randomization. So you have to adjust for things that are inherent in these designs, like selection bias and confounding. Sometimes we have time-varying exposures. For example, if a provider starts using an intervention halfway through a study period, patient outcomes before and after that switch must be modeled appropriately and accounted for. We might have multiple outcomes or mediators. Implementation studies often need to assess clinical, behavioral, and implementation outcomes simultaneously. Does fidelity to the intervention mediate the impact on patient health? Some common mistakes, or some common statistical challenges, I should say, missing data. So due to real-world conditions like staff turnover, technology failures, maybe a pandemic, outcome data are frequently incomplete. This is especially problematic, as we know, when data are not missing at random. And then multiple testing and mediation. So when multiple simultaneous outcomes and indirect pathways exist, type 1 error rates will inflate, and causal inference can become very complicated in that setting. So some common modeling approaches used in this area of research are mixed effects models, generalized estimating equations, interrupted time series, and mediation and moderation analysis. But as a biostatistician or a methodologist, your role in implementation science is to balance rigor with flexibility, applying robust methods while adapting to real-world data challenges. Close collaboration with your investigators during a design phase is essential to preempt analytical problems and ensure the analytic plans aligns with the realities of the implementation. So this just gives you a figure of what multi-level structures look like. We've got patient measures. The patients might be nested within providers. Nope. We got patients. The patients might be nested within providers. Providers are nested within hospital systems or clinics. And this matters because when units are nested, observations are not independent. Okay, so this is a slide that gives you an illustration of a basic demonstration of how to fit a multi-level model in R. How many of you have done this? Don't be shy, yell at me. How many of you have fit a multi-level model in R? Like a mixed model, a mixed linear effects model? I'm sure some of you have done this. It gives a basic demonstration of how to fit a multi-level model in R using a package called LME4. We're going to review this in the coming days. This is just an overview today. This is a powerful and widely used tool for hierarchical modeling. It starts by loading the package, which contains the linear mixed effects model function. It fits the model. Here, the model formula is blood pressure control is a function of intervention, clinic. And then, for example, here, the blood pressure control is the outcome variable. It could be a binary or a continuous measure indicating whether the patient has controlled blood pressure. The intervention is a fixed effect, This could be the presence or the absence of a new implementation strategy or program. And then this funny looking term, 1/clinic ID, this is a random intercept for each clinic. And this accounts for variability in baseline blood pressure control across clinics and for clustering of patients within clinics. So this kind of allows the observations within a clinic to be correlated because they're going to share that same random effect. And this is what actually happens in nested situations. So in implementation trials, patients are not independent. Those within the same clinic may experience similar environmental factors, training protocols, or leadership structures, and ignoring this can lead to underestimated standard errors. Okay, I don't know whether I need to stop here or if I can keep going. You all tell me. I can keep going? Okay, I'm going to keep going. I know I'm way over time now, but we had some issues at the beginning. I'm going to introduce the concept of hybrid trials now. Again, this is an overview. We are going to dive deeper into much of this in the coming days. So hybrid trials is a type of study design that looks at clinical and implementation outcomes at the same time. That's why it's called hybrid. It combines clinical and implementation research. This helps us understand whether an intervention works and how to deliver it within the same trial. So hybrid trials intentionally combine questions of clinical effectiveness with questions about implementation. This saves time and resources, and it brings research closer to the realities of real-world healthcare settings. It addresses both the outcome and the delivery questions at once. It enhances external validity and real-world relevance, which improves our confidence that it will work in a trial, that what works in a trial will work in everyday healthcare environments. It's useful for accelerating translation into practice, and it's increasingly supported by groups like in the US, the National Institute of Health, that fund designs. They want to see hybrid designs because it's not, again, enough just to show that something works if it's never going to be implemented in practice. So these are different types of hybrid trials, type 1, type 2, and type 3. In type 1, clinical effectiveness is primary, the implementation is secondary. So an example of this is a trial of new diabetes management protocols that primarily measure patient HbA1c outcomes, but also includes a provider survey on how easy the intervention was to use. A type 2 hybrid trial would equally emphasize both effectiveness and implementation, and these trials test both at the same time with the same weight for each. An example of this would be a SMART design, which we'll get to later, testing both delivery method as well as impact on patient outcomes with fidelity and uptake as co-primary outcomes. You can already see how we're starting to deal with multiplicity because we're dealing with multiple outcomes. And then a type 3 hybrid trial is where the implementation strategy is primary and clinical outcomes are secondary. You would use this when the clinical intervention is already known to be effective, but the goal is really just to figure out how to scale it up or down or deliver it effectively. Why do we use hybrid trials? To bridge the gap between research and practice, to provide insight into both what works and how to deliver it. By saving time, we save time by combining the two research goals, and improve the uptake of effective interventions. The takeaway message here is that hybrid trials help us move from knowing what works to making it work, and their growing use reflects a shift towards practice-oriented science and real-world relevance. So as an example to illustrate this, a type 2 hybrid trial, the goal might be test a diabetes self-management program. The effectiveness question is, does it work to lower HbA1c? The implementation is, well, do the providers actually use this intervention? And what are the barriers if they don't? And the design would be to evaluate outcomes, use surveys, observations, and electronic healthcare records to assess delivery. This combination allows us to link delivery process with outcomes, helping us identify what worked for whom and under what conditions. So choosing the right hybrid type really depends on the research question and the stage of evidence for the intervention. And this is a decision tree which asks the questions: is the clinical effectiveness of the intervention well established? If yes, do you also need to test implementation strategies? If no, maybe do a hybrid type 1 where we test effectiveness and observe implementation. And then we move on. After we're at yes, we ask, do you also need to test implementation strategies? If yes, maybe do a type 2 where we test both equally. If not, maybe just a type 3 where we really only focus on implementation and monitor effectiveness. Okay, so now we get into the meat. Statistical design considerations for hybrid trials. So this is going to be an overview of design and considerations for hybrid trials. Here are some key design considerations. First, define both clinical and implementation outcomes clearly. As always, in any good research, you have to pre-specify your outcomes. You can't just do this ad hoc, right? You pre-specify both the clinical outcomes and the implementation outcomes. We choose an appropriate randomization. Is it going to be the individual or the cluster? And consider how the intervention is delivered. If the intervention is delivered to individuals without risk of contamination, individual level randomization may suffice. But in implementation studies, delivery often occurs at the clinic or provider level, meaning cluster randomization is more appropriate. Also think about who is being randomized. Is it patients, providers, clinics, and what units of outcomes are being measured? We have to account for multi-level nesting or correlation within clinics or within providers, right? So we have to use an appropriate methodology of doing this so that we have appropriately estimated standard errors, and we don't have inflated type 1 errors. We have to plan for missing data and contamination risk. So we all know what missing data is, but contamination, what's that? It's when the control group may be exposed to the intervention. This is a real risk in implementation trials, and it will attenuate any effects that might actually truly be there, especially if randomization is at the individual level. So this is a really strong reason for using cluster designs or careful implementation fidelity tracking to manage this risk. These considerations are not, yeah, it would be nice if we have them. No, they are foundational to ensuring valid, interpretable, and useful findings. So upfront planning across these dimensions improves the feasibility, rigor, and translational potential of the study. We're going to go through this in much greater detail in the next few days. So some words on randomization and power and considerations for randomization and power calculations in hybrid implementation trials. These designs often depart from traditional individually randomized controlled trials. So let's break down what's important here. In a cluster randomized intervention, interventions are typically delivered at the system, provider, or clinic level, not directly to individual patients. This means that randomizing individuals is not feasible or appropriate, especially due to risks of contamination. Instead, we often use cluster randomization, where the units are like clinics, providers, or geographic sites. And this allows us to test implementation strategies while maintaining the integrity of the delivery system. Stepped wedge designs, which we're going to talk about next time, are common. Even though traditional parallel designs are useful, stepped wedge and factorial designs offer flexibility. The nice thing, as you will see about a stepped wedge design, is that every cluster or clinic will eventually receive the experimental treatment as part of the design. So nobody's left out. And that's usually a very attractive thing in getting providers to engage in implementation science research. But any power calculation must consider what we call the intra-class correlation coefficient, which measures the degree of similarity within clusters, multiple outcomes, which you understand. We may be evaluating both clinical and implementation outcomes, and cluster size and number. So power is more sensitive to the number of clusters than the size of each cluster. And it's often better to have more clusters with fewer individuals than a few very large clusters. And oftentimes we consider simulation-based sample size estimation because this just does not exist in closed form. So power and randomization are foundational to trial success. The design complexity requires thoughtful planning and often custom analytic approaches. Okay, so pragmatic trials. We're going to talk a little bit about what is a pragmatic trial. These are terms that you hear in implementation science research. So a pragmatic trial is essential in implementation science and real-world evaluation. It's designed to assess the effectiveness in real-world settings. So unlike an explanatory trial, which tests an intervention under ideal, tightly controlled conditions, pragmatic trials are designed to test how well an intervention performs in the everyday setting where it would be used. Think of pragmatic trials as answering the question, will this work in my clinic with my patients under normal conditions? Okay, so here we're also emphasizing generalizability and external validity. The pragmatic trial's focus is on external validity. So you might be thinking, how is this different from an implementation trial? It's in the outcomes. The pragmatic trials are still looking at the clinical outcomes, but in the real-world setting, where the implementation outcomes are about the uptake of the treatment. Is that clear? The difference between the two? Yep. Okay. So the aim is to answer, does the intervention work in routine care? So there is something here that's called a PRISIS-2, aligning trial with design with purpose. And this is a tool to assess how pragmatic or explanatory a trial is across 9 different domains. Sorry, that was the introductory slide for this. Those are the 9 domains. So they include eligibility, recruitment, setting, organization, delivery, adherence, follow-up, outcome relevance, and primary analysis approach. And the tool is a way to be able to assess all of these on a scale of 1 to 5. I'm not going to get into the detail here. It's just something I want you to be aware of that exists out there. And then it can be plotted this way. So the framework is used in practice by something called a PRISIS wheel. And this is a chart that gives us a visual snapshot of what this design, design looks like in terms of how pragmatic it is. The center of the wheel reflects a highly explanatory trial. So if it's very explanatory, you get lower numbers. And as you have more pragmatic trials, you get higher numbers. So the more of this circle is within the shaded area, the trial is more pragmatic. So it's a visual tool to allow investigators to see how pragmatic a trial is. So again, this is to kind of clarify that point of confusion of how pragmatic trials relate to implementation science trials. They're often seen together and they do overlap, but they serve different primary purposes. Pragmatic trials focus on clinical effectiveness, while implementation trials focus on delivery strategies. They are complementary, they are not identical. You can have a pragmatic trial with no implementation component, or an implementation trial that monitors but does not prioritize clinical effectiveness. This is where that hybrid trial comes in. It can do both at once as a bridge between pragmatic, effectiveness, and implementation goals. So in summary, pragmatic is what works in real life, and implementation is how do we deliver it well. I'm just going to keep going until somebody tells me I have to stop. So this is just a summary slide of the key distinctions between pragmatic and implementation trials. Again, I think I've said that clearly enough. The takeaway here is that both trial types are essential to move from research to practice. Pragmatic trials ensure interventions are effective in real-world settings, while implementation trials ensure we can deliver these interventions widely and sustainably, and they can be integrated in a hybrid design. I'm a real big fan of a hybrid design. So this slide brings together the overlapping features of pragmatic and implementation trials, which are both essential in real-world research. The take-home message from this trial is that while pragmatic and implementation trials differ in their primary focus, clinical effectiveness versus delivery strategies, they share a commitment to real-world relevance, methodologic flexibility, and the goal of informing practice and policy. This overlap makes them ideal candidates for hybrid designs, maximizing both the scientific insight and the translational impact. Again, this is a slide with very small words. You probably can't read it all, but it's a slide that you will have in your copy of my notes to summarize the 4 different trial types we used in clinical and implementation research: explanatory, pragmatic, implementation science, and hybrid. So up until this point, I think we have thoroughly reviewed these different trial types. So when we use this language moving forward, it will be clear what we're talking about. So as an illustration, let's look at a concrete example of the evaluation of blood pressure lowering drugs to illustrate how explanatory, pragmatic, and implementation science and hybrid trials differ in focus and design. For the explanatory trial, the focus is on efficacy. Can the drug work when everything is optimized? For the pragmatic trial, the question is, does the drug reduce blood pressure in real-world clinical settings? So this is testing effectiveness, but in a real-world setting. In implementation, the focus is on, does provider training improve the adoption of drug X? So the outcome of interest here is not the clinical outcome, it's did the provider adopt the drug? And the hybrid trial integrates both. Does drug X work in real-world practice, and does training help implement it? This example illustrates how each trial type addresses different but often complementary research questions. Okay, so now I'm almost done. Now we're gonna switch gears a little bit and talk about clustering. These are all the key concepts we're gonna need for the next 2 days. Clustering happens when individuals in a study are naturally or intentionally grouped into larger units, such as patients treated by the same physicians, students in the same classroom, or residents in the same community. These individuals tend to be more similar to each other than they are to people in different groups. For example, patients at the same clinic might receive similar care, follow similar protocols, or live in the same neighborhood, which introduces correlation in certain outcomes. This correlation violates any assumptions of independence that underlie many standard statistical methods, right? So if we ignore clustering, what does this do? It completely messes up our estimation of our standard errors, usually inflating our type 1 error rates and drawing invalid conclusions. So to account for clustering, we may use cluster randomized designs, calculate something called the intra-cluster correlation coefficient during our sample size planning, and use multi-level or mixed effects models in the analysis. So this is how clustering affects standard errors in power. It summarizes what I've basically just said. Clustering will reduce your effective sample size. So when individuals are clustered, the patients are more alike within groups. We induce something called intra-class correlation, which inflates the variability of our estimates if we ignore it. The key consequence is that the effective sample size is smaller than the number of individual participants. For example, if we have 100 patients from 5 clinics and this is not as informative as 100 patients from 100 clinics, because the patients within a clinic are kind of overlapping in the information that they're giving us because they're positively correlated to each other. This loss of information shows up as larger standard errors, meaning confidence intervals get wider, power gets reduced, and we're less likely to detect any true treatment effect. So to compensate, we need a larger total sample size, more clusters, or statistical methods that properly account for clustering, like mixed effects models or the use of generalized estimating equations, or GEE. Ignoring clustering is one of the most common and dangerous mistakes in the design of analysis of implementation and pragmatic trials, so recognizing it early and having statisticians involved is essential for valid inference. This slide helps us clarify a crucial decision in trials, especially in implementation research and pragmatic trials. What is the unit of randomization? Let's first define what that means. What is the unit of randomization? This refers to the level at which an intervention will be assigned or delivered. This could be individuals, like patients. It could be clusters, like schools, clinics, communities. Choosing between these has implications for both feasibility and statistical rigor. If we use individual randomization, it might be considered statistically efficient because it gives us more precision for a given sample size, since there's no need to account for intra-class correlation. There would be less contamination because each person is randomized separately. There's less risk that behaviors or care from one group will spill over to another. There may be greater internal validity. The design offers stronger causal inference, and it's often favored in explanatory trials. However, it requires greater control over the intervention environment, which may not reflect real-world care. And it might be unrealistic for delivery of some interventions. Think an interventional tool to help train patients when they're first diagnosed with diabetes. You can't really randomize that at the interventional level when the training is going to the physicians and the nurses in the clinic. Cluster randomization is often more feasible when the intervention is targeted at a provider, team, or system level rather than individual patients. It reduces logistical complexity. All the patients at a given site get the same protocol. Yeah, I'm in the right one. All the patients get the same protocol. Cluster randomization is a better fit for implementation strategies, which are typically delivered at the level of clinics, providers, or organizations. But there's a trade-off. I always say nothing in life worth having comes without a cost. There is a trade-off. You need more clusters to detect effects because this intra-class correlation decreases statistical power. So the choice of a randomization unit is a balance between statistical rigor and real-world feasibility. So now let's talk about, I keep talking about this thing ICC, intra-cluster correlation coefficient. What is that? It quantifies how much of the total variability of an outcome is attributable to differences within clusters as opposed to differences between individuals within the same cluster. So it's breaking down variability into what's intra-cluster and among the clusters and what's within the clusters. Intra within, inter between. So mathematically, it's the ratio of the between cluster variability to the total variance. So ICC can be expressed as the between cluster variance over the total variance. It's in there somewhere. It's up there on top. Okay, so the ICC tells you how similar individuals within the same cluster are. If it's close to 0, it really means that you can ignore it. Individuals within a cluster are not very similar. The cluster structure doesn't really matter much. But if it's large, that means individuals within a cluster are nearly identical. Think about the extreme. If I have 20 clusters, each with 5 patients, and my ICC is 1, that means I'm only getting one piece of information from each cluster because every observation is identical for the patients within a cluster. So I don't get any more information by having more patients within a cluster. Does that make sense? Okay. So ICC can go from 0 to 1. 0 means no correlation. 1 means perfect correlation within a cluster. And most implementation studies find that ICCs go in the range between 0.01 to 0.1. But even small ICCs can have a major impact on design and power. And that's because ICC affects the sample size. The higher the ICC, the greater the sample size you need, because there's less independent information when people in the same cluster are highly correlated. And we account for this using what's called a design effect, or a variance inflation factor, which adjusts the required sample size based on ICC and cluster size. It affects the statistical power because if we ignore clustering and don't account for ICC, our standard errors will be underestimated and the p-values will be overly positive, very misleading. And this can lead to type 1 error, false positive, or overconfident conclusions. So in modeling choices, we have to use modeling choices like multi-level models or generalized estimating equations or other methods that appropriately estimate the standard errors while accounting for the clustering. So ICC is subtle but powerful, and even modest ICCs can substantially affect the design considerations. I'm really almost done. Time's up? Okay. All right, so I will continue here. I know time's up, but I'm just gonna show you really quickly. This is the definition of the design effect. It actually gives you the quantitative value that your sample size will increase by according to that design effect. So your effective sample size ends up being n over your design effect. So this allows you to know how is my design being affected by the interclass correlation. And that is an example of how the ICC affects, the ICC and cluster size, what is the effect on the design effect. So the important thing to note here is that this chart emphasizes that ignoring clustering or underestimating its impact will lead to underpowered, inefficient, or misleading trials. You can see how the design effect goes up quite a bit as cluster size and ICC increase. So these are different levels of ICC, this being the smallest. This is different levels of ICC, this being the smallest, where that's the biggest. And we can see that the design effect increases when cluster size and ICC goes up a lot. So the take-home message is we cannot ignore the design effect. Here I've just got some coding in R to be able to estimate design effect and ICC. And this is an overview of modeling strategies that we will talk about for the next 2 days. Okay, so now I'm gonna stop. I apologize that I went way, way over, but I think that in the next couple of days that won't be as much of a problem. So thank you for your time, and I will see you tomorrow.